times. And it's indigenous not just to the ICU, but I know some of you guys are combined ER and IM and FP and EM. And, you know, there's always been a major concern for airway management, because if you don't have an airway, you don't really have anything. And, you know, how you go about dealing with airways is an important matter. And I guess what you have to learn over time is how to stay calm under any and all circumstances. And the other thing you have to understand is that when you get into airway management, and you'll hear this like repetitively at all these difficult airway courses, that you know, about like 95% of people can be, you know, bagged successfully. And people forget that, and everybody panics, and they try to do things, but often you can just maintain an airway with a bag and a mask. And then it's the other 5% that are going to be a problem. And apparently there's like 5% of people are going to be difficult airways. About a few percentage of airways are going to be people that you cannot intubate at all. And that's where the real problem is. But you got to learn to stick to basics. When you get into practicing medicine in general, you got to learn to stick to basics, and you got to learn to go through things in a stepwise fashion. If you're in a situation where there's a problem, you have to be able to sort of take control of that situation and maintain calm, and stop and give everybody their assigned task. Because I'll like walk into a room and the room will be in chaos, and you just have to sort of take control of the room and sort of say, you do this, you do this, you do this, and the rest of you please leave the room. Because there's, you know, whenever there's a problem, there's too many people around, there's too many voices, and you really have to get rid of the people that are not important, keep the people that are indispensable, and then give everybody an assigned task. And just stay calm. And there's going to be times where everybody panics, and there are going to be those times, but you try and minimize those times. So that's just a preface to what we're going to talk about. And so again, we're just following along that Fundamentals of Critical Care Medicine book. And so when you first go see a patient, we sort of alluded to this last week. You know, what do you have to do when you know, go assess a patient that's critically ill, and you're paying particular attention to their airway? There's certain things that you want to look at. You want to see, are they able to protect their airway? Because you'll walk into a room and the patient will be saturating well and just lying there, and they may not be able to protect their airway. Some years ago, I went up to do a consult in a patient at the Bucks campus, and I walk into this room, and this patient's laying in the bed, in the middle of the bed, and they're like totally out of it, and the family's just like in chairs around the room, and they're like watching this body in the bed essentially. But the body in the bed had a very good O2 saturation. It was like 90-something%. And for some reason, they had been unable to obtain a blood gas on this patient. So I walked in and I obtained a blood gas, and it took about 30 seconds to get one. I don't know what the problem was. And the PCO2 was about 160. And the patient had been sitting there for 48 hours prior to that consult, laying in that bed unconscious, unable to protect their airway. They were intubated, they woke up, they were subsequently extubated. And you know, so you have to assess the level of consciousness. And just because somebody's satting well doesn't mean that they're a stable patient. And that's a lesson that you have to learn. And that's not an easy lesson to learn, because you'll hear that argument all the time, but they were satting okay. You want to see what type of respiratory effort they're doing. When we talked about abdominal paradox, are they using accessory muscles? You know, are they tachycardic as well as tachypnic? Are there signs of impending failure? You want to assess them for possible injury. It could be an airway injury. They could have facial trauma. They could have had you know, something affecting the base of the skull that's going to affect the way you approach their airway. There's all these different considerations that you have to have as you go through the assessment of the patient. You want to see, are they moving enough air? Do they have a flail chest if it's a trauma patient? You want to listen for breath sounds and make sure that they're reasonable. And you want to judge whether somebody has an upper airway obstruction, which we had to look at the other day in the patient in bed 14. Do they have stridor? Is it a cough or is it stridor? Too bad Sean's not here, yeah. So we walked into a room one day and this woman had been intubated. We extubated her and within 20 seconds she was making these very strange noises. So I turned to Sean and I go, you think it's a cough or stridor? And we go, we don't know. Within about half a minute, she had an O2 sat of about 50%, and we decided it was probably stridor. And so now when I would extubate anybody with Grammy present, he would have an ambu bag ready in case there was a cough versus stridor. So how do you establish an airway? And this is all very simple stuff, but you know what? When, excuse my language, when the shit hits the fan, man, people forget all the basic stuff. People panic. The first thing you should do when you're running to a code is check your own pulse, okay? And you want to make sure it stays reasonably okay, because you want to stay calm. And so what happens is people just forget. Somebody goes like, where's the bag? Where's this? The bag is sloppily put on the face. Nobody goes and establishes the airway. I mean, you can attest to this from having been in the emergency room or at code situations, right? Mm-hmm. Nothing takes place in a systematic manner. So you, as the person in the room, has to say, okay, this patient is not doing well, we're going to establish an airway, get them in the proper position. So you want to extend their neck, elevation of the mandible with a jaw thrust, get their mouth open. If there's a C-spine injury, or if you think there's one, you want to have hands on the side of the neck to stabilize the neck. And you can intubate people that way. That's like actually a critical care board question. Do you fiber optically intubate those people? Do you do certain other maneuvers? No, you have to get an airway. So you stabilize them manually and you intubate them. But you have to get them in a proper position. And once you get them in the proper position, you get them in a position to be bagged effectively as well. Because like I said, 95% of the time you're going to be able to bag a patient. And there's times here, and I'm not an expert in airways, where there's been a sick patient and we have to wait for anesthesia and we just maintain that patient by bagging. I mean, everybody wants to do something and it's like, no, they're oxygenating, they're ventilating, we're able to bag them, don't do a damn thing. Because if you're not an expert and you start mucking around in that airway and then they get airway edema, it becomes a whole different level of complexity. And that's when you start to lose your sphincter tone, right? When you get to that next level of complexity. Because people will die very quickly without an airway. And if they don't die, and they end up with an anoxic brain injury, that's even worse than them having died from a medical legal standpoint. Somebody dies and you get sued, it's cheaper than if they live and have a significant injury. It's sad but true. So you really want to maintain calm, you want to maintain the airway. Okay, so we're going to talk a little bit about adjunctive devices. So once you get them in the proper position, you want to make sure that they can be bagged effectively. And we don't often do this, but we should. You can either use a nasopharyngeal or an oropharyngeal airway. So, I don't know that we want to open these things up. Okay. Can we? Yeah. So this is a nasopharyngeal. And these can be used for suction, but they'll also maintain some patency of the airway. And you can use them. They come in different sizes. They're pretty flexible. Don't forget to gel these things up. And what I do often is I'll just get the Eurojet stuff, and it's got lidocaine in it, and it'll numb up the patient as you're putting in, the nasopharyngeal airway. I'll do the same thing when I do bronchoscopies, or the same thing when I put in Dobhoff tubes. When you guys are out there, if you want to think about your patients a little bit, you take a small Q-tip, you take a little bit of lidocaine gel before you're going to pass a tube through them, and you get a good feel for the nair, and you can numb up the patient. And it's a more pleasant experience for them, because this is not a pleasant experience. And you can use these in awake patients. You can estimate, really the size just by looking at the patient. Because you don't want to get too deep into the oropharynx, because you can actually start to get a gag and impede the airway. And so you guys can just pass these around and look at them. And they're put in sort of in like a twisting manner. Sort of put them into the side and then just twist them into position. And the other thing you need to think about when you use oropharyngeal or nasopharyngeal airways is if you're going to use a nasopharyngeal airway, make sure the patient isn't coagulopathic. Make sure the patient doesn't have a basilar skull fracture. There's some great x-rays if you go onto the internet of like NG tubes in cranial vaults that people have passed through basilar skulls into the brain. There's such a thing as brain food, but that's not the way you want to get it. So those are the contraindications. And whenever you're passing tubes through somebody's nose, always know what their coags are, because if their coags are off and you hit a vessel, you got another whole world of trouble. And people don't think of NG tubes or DAVHOPs as procedures, but they are. And you have to know what the patient's coags are and what their state is. So that's the nasopharyngeal, and then I think we have some oropharyngeals here. Here's the oropharyngeal. So the oropharyngeal, you can also estimate the size just by looking at the patient, and it gives you a feel. And you want to put it in like in a twisting manner. And they're very helpful when you're bagging somebody. It'll keep the tongue from flopping back. If it's too long, you can cause gag, and you don't really want to put it in a conscious patient because you'll cause a gag. If it's too short, you may actually push the tongue back and occlude the airway. So you want to be careful about that. So that's the pictures of, and that's sort of, they show you, so you're starting with the flange and upwards, and then you're rotating it around. And so those are your nasopharyngeal and oropharyngeal airways. And they are very helpful. So the oropharyngeal will hold the base of the tongue forward, don't insert it for reflexes, and again, contraindicated for coagulopathy or basilar skull fracture for the nasopharyngeal. Okay, manual mask ventilation. So we're always looking for the bag. I don't know if we have a bag here. I wonder if we can grab one from outside. From one of the rooms, yeah. See if there's one in one of the empty rooms. So this is your key to maintaining an airway before you can get a patient intubated. And certainly you want to make sure their mouth is clean. It's nice if you have an oropharyngeal or nasopharyngeal airway in place. And you want to, bag the patient. If the patients are somewhat awake, they'll still accept the bag usually, as long as you talk to them and reassure them and bag them in synchrony with their respiratory effort. Sometimes people that are claustrophobic will have quite a bit of difficulty with the bag. In the unconscious patient, obviously, it's easier to do. When you bag them, you don't want to forcefully bag them too much. And you sort of want to gently bag them, and the other thing you want to do is get a feel for the resistance that the patient has. So, I guess we're going to blow another bag, huh? What's that? Here's the bag. You guys can pass these around. You can try them on each other. And so that bag will be hooked up to 100% oxygen, which is usually 15 liters flow or greater. There will be times when people are being bagged that they forget to hook up the oxygen. You've seen that, right? So you're bagging the patient, the sats aren't coming up. Always check and make sure that the oxygen's been hooked up to the bag. Like, how many times have you seen that?
Probably twice.
Yeah, I've seen it quite a few times because people panic, they get the bag on, they forget to hook it up to oxygen. So you're ventilating the patient, but you're not oxygenating the patient. And then all of a sudden you hook up the oxygen and the sats go up and you go, wow, this is pretty cool, right? So So when is it indicated? So it's indicated if there's apnea, if volumes are inadequate. So even if they're breathing spontaneously, like I said, you can use this adjunctively. Reduced work of breathing and hypoxemia. The other times that I've used it is I've gone into a room and somebody's somewhat hypercarbic, and instead of first putting them on BiPAP, you can gently bag that patient and bring their CO2s down, and sometimes wake them up to the degree where they're now in a position to be placed on non-invasive ventilation. And it's sometimes helpful in that manner. And I've done that a few times, and it's like magic, you know? Makes you look pretty good. Patient wakes up.
I actually had two questions. One was you talked about somebody who's had the reduced work of breathing, but they're still semi-conscious.
Right.
Is there an indication when it's safer to use an oropharyngeal airway? 'Cause it's like, if they're semi-conscious, they may or may not.
Yeah, I think you have to play that. I mean, you can test the water. When I used to do bronchoscopies as an outpatient, you know, I would test the water in this manner. I would spray the patient up with like with lidocaine, and it would be in a little atomizer. And first I'd numb up their nose, and I'd numb up their throat. I would take the atomizer and I would gently go to the back of the throat and sort of gauge their gag reflex. And you can certainly take, you know, anything like a Q-tip or a tongue depressor and check out their gag reflex, you know, to test the waters. And if you see they have a vigorous gag, you're not going to put an oropharyngeal airway in. If you see that they have no gag at all, you probably could get away with it. The other thing is that like 15% of the population has no gag reflex, which is sort of an interesting thing on many levels. And I'm going to leave it at that. I'm going to leave it at that. So anyway, that's... I'm trying to keep a straight face here, but that's a little known fact, and that comes into play when you're dealing with people for speech evaluations and aspiration. But I'm going to leave that alone now. So let's move on. So apnea, inadequate volumes, reduce the work of breathing if they have increased work of breathing, and hypoxemia.
The second question was some of the bags are different. Some of them have valves, like PEEP valves.
I was going to say some have valves and some don't. Now, when you have a patient that's severely hypoxemic, and you know they're going into respiratory failure, and they have an alveolar filling process, and you're waiting to intubate them, the institution of a PEEP, you can put a PEEP valve on those things. The other thing that will happen sometimes that you've probably seen when you've been in the unit is that somebody will decompensate when we're doing a procedure, or they have sudden decompensation, and you take them off and you bag them. And those patients could be on a significant amount of PEEP. So you really want to have PEEP on that bag as well, so you don't lose your PEEP effect. No, so I was going to mention that, so I'm glad you asked that question. So that can be very helpful in somebody that's got an alveolar filling process and is severely hypoxemic. So in order to successfully do mask ventilation, you have to have an open airway, you have to establish a tight seal. You have to make sure you deliver an adequate minute ventilation, which for a normal person is probably about 12 to 15 breaths per minute. The oropharyngeal or nasopharyngeal airway may be helpful. You want to stand behind and above the patient, right? And you want the base of the mask between the lower lips and chin. And you want the apex of the mask over the nose. And then you want to sort of grasp from the left side and seal down. And what you can actually do is bring the cheek up to seal down and put some gentle pressure down to seal the bag. You know, you get into it and every once in a while you start to bag somebody and you feel that there's no resistance, you know that you probably don't have a tight enough seal and that you've created an air leak. And that's very important. Alternatively, you can use two hands. You can wrap them around at the base of it and bring it to the apex and hold the mask in place. But if you're going to do that, you need a second person that's going to squeeze the bag. So the first way is like a one-person method, and the second way with two hands is a two-person method. But you have to make sure you have that decent seal. And if you started bagging them without having an oropharyngeal and nasopharyngeal airway and you're not having much success, often the insertion of either one ensure that you have a better degree of success. So stabilize a mask with the left hand, apex between the thumb and the first finger. Base is around with the third and fourth fingers, third, fourth, and fifth. Raise the jaw, extend the neck, get them into the proper position. And if a C-spine is the AV guy that went out on us.
Try unplugging it and plugging it back in. That's seemed to work in the past.
I guess this is intermission.